See important safety information at the end of the video.
My trialing process for low-dose intrathecal drug delivery is usually a 3 or 4 day process. On day one, an intrathecal catheter is placed into the intrathecal space posterior at the dermatomal level of the pain. And this, for instance, for failed back surgery syndrome would be at approximately T10 to T12. Once that catheter is placed, the patient gets the first of 4 doses of medication. The first dose of medication would be 50 micrograms of morphine. Second dose would be 100 micrograms of morphine. Third dose, 200 micrograms of morphine. And the fourth dose would be placebo. If a patient is going to get placebo, they have to be consented up front that one of their doses is going to be placebo. And the patients are told up front that they'll get 1 of 4 doses in random fashion. If a patient responds to one of the doses, 24 hours later, they will get a placebo dose. And as long as they don't respond to that placebo dose, then the trial is considered a success and they will go on to permanent implant. If the patient doesn't respond to the first dose, they get the second active dose, and so on. I would go as far to say that weaning oral opioids, systemic opioids, is mandatory to have a successful targeted drug delivery program. And I would also say that if you're not going to wean patients off of their systemic opioids, it's probably not worthwhile going forward with this therapy. That may seem like somewhat of a strong statement, but I have experience with not weaning patients off of oral opioids and seeing the results associated with that, and the results are so much better with weaning that I really think that that should be a mandatory step of everybody's workflow. The reason why it works is because the receptors become more receptive once a patient has been tapered and has undergone a holiday. I also feel that the holiday is mandatory to make those receptors more responsive to the medication. How long the holiday has to be is really up to the provider. I think the longer it is, the better. I currently use a 6-week holiday prior to doing a trial, and that works well. The next question is, how do you wean? And I really don't care how a patient weans as long as they wean. Some patients may take a long period of time to wean, and that's fine as long as they're actively weaning and progressively weaning their medications. Most patients want to wean pretty quickly because they want to get to the therapy as soon as possible, so that's fine as well. In my particular practice, the primary care providers are actually fine with doing the weans themselves as long as I give them recommendations and take an active part in the process. So that works pretty well for me now. Since I've been doing this therapy for quite a long period of time, primary care providers now are actually weaning the patients on their own and then sending me the patient as a referral for a pump. So that works nicely too. And that's largely based upon the success of the therapy. The primary care providers have really bought into this therapy, realized that it works, so they go ahead and do the wean up front. I don't really think the patient category would actually change. I think I would still utilize the same patients. The difference is really utilizing the therapy as a salvage therapy. The therapy should not be a salvage therapy. If this therapy is just used for the patients who have the worst responses with everything else, this therapy is going to fail as well. So I think the key difference in what I do now is that I don't use it as a salvage therapy, and I think that's a really important point. In terms of specific patient selection, there's so many patients out there that could benefit from low-dose targeted drug delivery. Patients with spinal stenosis who did well with injections for a while but are no longer responding to injections. Patients who do well with systemic opioids but have significant side effects from their systemic opioids. Patients who have regional pain syndromes such as chronic abdominal pain or chronic pelvic pain, things like that. Patients who have post-thoracotomy pain syndrome. So as long as patients have a regional pain syndrome, they have gotten psychological clearance, I think they're reasonable candidates for this therapy. Dose escalation is a big problem with both systemic opioids and targeted drug delivery, and it's something that really needs to be avoided. We talk now a lot about avoiding dose escalation with targeted drug delivery, but we really should avoid dose escalation with systemic opioids as well. Most patients are always looking for the perfect pain score, and in most patients' eyes, the perfect pain score is no pain. So you really have to counsel patients up front that they've had chronic pain for several years. That pain's not going to go away, but we can make it lower significantly. I usually tell patients a good response is 50% improvement with functional improvement as well. And if they're at 50% or 60%, that's significant improvement, and they're a lot better than they were before. And you have to keep telling the patient that over and over. The other pitfall with this therapy is, in order to have a successful targeted drug delivery practice, there's not just the provider. There's also the RN, there's the medical assistants, there's the mid-levels, etc. And everybody has to be on the same page. When I first started doing this therapy, we were getting patients pretty good results, but the patient would come in and see my RN or my mid-level and not see me personally, and they would say, yeah, I feel better, I'm about 60% better, but I want to be a little better. And I found my mid-levels and my nurses increasing the doses and searching for that perfect pain score. So you really all have to be on the same page, and I think that's a very important concept for anyone who wants to develop a targeted drug delivery practice.
Important safety information. The Synchromed 2 infusion system is approved for the long-term delivery of preservative-free morphine sulfate sterile solution and preservative-free ziconotide sterile solution directly to the fluid around the spinal cord for treatment of chronic pain. Targeted drug delivery should be considered after the patient has tried oral medications or other therapies that have failed or were associated with intolerable side effects. Implanting the system has possible risks, including infection, meningitis, spinal fluid leak, paralysis, headache, swelling, bleeding, and bruising. Pump or catheter problems can cause a patient to experience overdose or underdose and/or corrective surgery. Errors in inserting the needle into the pump refill septum during the refill procedure can result in medication being inadvertently injected into the pocket, resulting in an overdose that may be life-threatening or fatal. Drugs infused through the system may result in adverse events. Refer to appropriate drug labeling for prescribing information and detailed disclosure. Formulations not indicated in product labeling may contain neurotoxic preservatives, antimicrobials, or antioxidants, or may be incompatible with and damage the system. A prescription is required. Healthcare professionals must review the product technical manual and appropriate drug labeling prior to use for detailed disclosure. For complete safety information about Medtronic targeted drug delivery, call Medtronic at 800-328-0810 or visit Medtronic's website at professional.medtronic.com/IDD safety.